Thank you everyone for joining. While people are logging in, please feel free to go ahead and introduce yourself in the chat and say your name, organization, and where you're joining from, and we'll get started in just a moment. Thank you, and we'll go ahead and get started. So if we could advance to the next slide. And Dr. Zinau, I'll pass it on to you. Dr. Zinau, it looks like you're on mute. If you can hop off mute and go ahead and give your welcome remarks. Thank you.
Okay, thank you, ladies and gentlemen. Good morning, good afternoon, good evening. My name is Zena Adam, the Technical Director of the Universal Immunization Project. On behalf of JSI and Universal Immunization Project, I thank you all for joining us today to share our work of RED-QI implementation and its progresses made in Ethiopia over the past 10 years. This work was fully funded by Bill and Melinda Gates Foundation, which were very grateful. I will start by inviting Mr. Johannes Lacko, the Assistant Director of the Maternal and Child Health Directorate at the Ministry of Health and the National Coordinator of EPI. Please join me to welcome Mr. Johannes.
My name is Johannes Lacko. I'm currently working as an Assistant Director for Maternal Child Health Directorate at the Ministry of Health Ethiopia. I am also working as a National EPI Manager. So I am honored and pleased to make a keynote address for this closing session of Universal Immunization through Family Health Program. As you know, immunization is one of the most effective public health interventions globally and as well as in a country level. The immunization program is a core component of a global, regional, and the country level agenda. Ethiopia boldly stipulated the immunization program in the health sector transformation plan, which starts from 2021 and ends in 2025. By aligning with the global targets like SDG considered in this planning process. Ethiopia has developed an immunization-specific 5-year strategic plan, which runs from 2021 to 2025. With this, to give you some highlights on the immunization program, the expanded immunization program, the EPI has 43 years of experience in Ethiopia. Currently, about 12 routine antigens have been given for the public freely. Over the last 4 decades, the immunization program progressed a lot in terms of coverage as well as in terms of introduction of new vaccines and underutilized vaccine. So over the last 4 decades, the immunization program progressed a lot in terms of coverage as well as in terms of production of new vaccines and underutilized vaccines. Despite all the successes, there are inequalities of performances or coverage across different parameters like geography, educational level, urban and rural residency, and other factors. In Ethiopia, the immunization service is expanded through health extension program, which is a major activity of the Ethiopian Innovative Health Extension Program. There are 3 different service delivery modalities in the country. One is the fixed one, the second is outreach, and the third is mobile team to reach children in need of the vaccine. Ethiopia also implemented different initiatives or strategies like RED strategy, PIRI, which is a component of the RED strategy to strengthen and reach every child. Different developmental partners has been supporting Ethiopia to reach every child to avail the vaccines and vaccinate more children. Among these partners, JSI Universal Immunization through Family Health Service is one of that. JSI Universal Immunization through Family Health Service has been supporting the country and achieved a lot of children has been vaccinated through this project and prevented different vaccine preventable diseases across all these years. The very good nature of this project was they did in the health system, strengthening part, and in areas where no partners are willing to implement or support, and in hard to reach areas, especially in the pastoral parts of the country. Finally, I would like to thank the donors of this project, Bill and Melinda Gates Foundation, JSI Universal Immunization through Family Health Service Project, the director of the JSI Universal Immunization through Family Health Service, Dr. Lisa Oot, and all the staffs who has been working with us for children of Ethiopia, for the well-being of the children of Ethiopia. I hope this innovative project will continue with other forms of modality or as it is in the coming years. And I wish this closeout meeting will have a good deliberation and successes. With this, I would like to end my keynote address here and thank you for your time and attention. Have a good time and have a good discussion. Goodbye. Thank you.
Okay, thank you, Johannes. I will take the facilitation role. I am Theodros, working with JSI Universal Immunization Project as Senior Immunization Program Advisor. Next, we will share UI-FHS closeout video. As you will see from the presentation of today, addressing inequality in immunization was one of the core components of Universal Immunization Project. And the following video will show how JSI addressed inequity of immunization using a RED QI approach. Samantha, please to the video.
Achieving equity in healthcare means access for everyone, regardless of who they are or where they live. But when it comes to immunization, inequity persists. Advances made in immunization over decades have plateaued globally, leaving millions of children susceptible to vaccine-preventable disease. The gap is widening in Ethiopia, which ranks 6th in the world for the number of children without any vaccination. Remote, rural, and nomadic communities are particularly vulnerable because resources and access to quality healthcare are limited. To increase immunization equity, JSI and the Ministry of Health designed RED QI, an approach that uses quality improvement tools to strengthen the country's national strategy, reaching every district. At facilities in hard-to-reach places, healthcare workers engaged clan heads and community leaders in immunization microplanning. They asked them to join quality improvement teams to leverage their knowledge of local communities to solve problems. Together, they drew catchment maps and identified underserved communities to determine where and when to immunize, ultimately mobilizing communities to seek services. QITs helped institutionalize the practice of tracing children who missed immunizations, an effort that increased at facilities over time. For the first time, facilities conducted headcounts of target populations, so they knew exactly how many children needed to be reached. Healthcare workers were routinely coached on the job and provided easy-to-understand problem-solving tools. Skills retention and performance among healthcare workers increased, improving their ability to plan and manage their facilities' immunization services. Because of a decade of success, the Ministry of Health incorporated Red QI practices into its national guidance for immunization programs. The Red QI approach is a powerful way to increase immunization equity and close the gap so that all children around the world can be protected from vaccine-preventable disease. Learn more.
Thank you, Samantha. Yeah, that was briefly showing the role of Red QI in addressing inequity. Next, I invite Dr. Zainab Adam, the project technical director, to share with us the 10 years of achievement of the project. Dr. Zainab, to you.
Thank you, Teddy. When I present this 10 years of progress, actually it is 3 parts, one following the other. So I would like to bring to your attention that this is a 3-part of 10 years work. Next slide, please. Just to give you a few things about the background, Ethiopia, as indicated earlier, immunization program has been, implemented over the last 3 decades, but still access and utilization of services continue to be a challenge in many parts of the country. In due course, Ethiopia also implemented the RED strategy, but after 10 years of implementation, there was no significant performance improvement seen. There were continued a number of cases of vaccine-preventable diseases and outbreaks, even in areas of high administrative reported coverage. Next slide, please. Next slide. Samantha, next.
Oops, sorry, I think we've lost Sano. Let's go back to the objectives. Dr. Zen, are you still there?
I'm sorry, there was a disruption. Excuse me. And with that background, actually, this project was initiated with the following objectives. Number 1, as to why the implementation of RED is not working. So we wanted to unlock by studying or developing a model that will be more effective, sustainable, and affordable. And also to answer the question as to why children were still developing cases, even though in some areas of the country there was high coverage. So we conducted a combined coverage and sero surveys also to see the effects of RED QI over time. And also, as we all know, immunization is stakeholders engagement. It's a program that needs as many stakeholders be engaged and own the program for its success. And the project was also working on that engagement. Finally, with the results of the Red QI implementation over the first period, we wanted to scale up to take the implementation to more areas where immunization services are inequitable. Next slide, please. So the overarching goal was to enable the health system to respond to the needs and to deliver equitable service to all, particularly in the remote and the pastoralist areas of the country, where, as you see in the picture, people are on the move constantly in search of water and grazement. Next slide, please. So the first part, this first part of the 3 parts, was developing the Red QI model. As I indicated, as one of the objectives was to see as to how we best operationalize the Red strategy and learn more from it towards improving the immunization system in the country on selected 3 learning worlds in different contexts. Next slide. Next slide, please.
Sorry, I think he's froze again. Let's go back to this slide. So let me just help him out while we get him back. So Red QI is an approach where we've added quality improvement tools and methods to strengthen each component of the Red strategy. So in this slide here, we've outlined the 5 Red components and the tools that were used to strengthen the different components of the Red approach. So for example, under planning and management of resources, we used quality improvement tools, such as the fishbone analysis tool, and I see Dr. Zeno is back, to help improve the planning process. And part of that was really engagement of community and civil administration in the planning process as well. I'll turn it back to you, Dr. Zeno.
Thank you, Lisa. It's very unfortunate the power is interrupting. Anyway, in case it fails again, I love to invite Lisa to continue. So I think the Red QI approach is a very equity approach, pro-equity approach, based on the Red strategy and its 5 components. And on each component, there was a built-in elements of Red and QI. The quality improvement elements were incorporated in the components of the Red strategy. As you can see, during the planning, use of quality and improvement tools, and also to reach the target population. That's the most important thing. Reaching the unreached target, we build the capacity of health workers to develop mobile and outreach service delivery. And also the community as the primary owner and supporter of the program, we engaged communities very well, especially in key activities such as micro-planning and also revitalizing the quality improvement team with members from the community fully involved. Another area is the supportive supervision, which we use as a very capacity building tool, where health workers were developing data and informing planning for supervision, and also iterative holistic support based on needs. So it's a 2-way learning process supporting supervision is a very key element. And finally, the monitoring. Monitoring and using data for action. One of the key elements in the Red QI is just using data from the point it is generated. And as you see from the picture, health workers and quality improvement teams are monitoring progresses of immunization services and use data through all processes by meeting regularly and reviewing data that they generated. Next slide, please. Okay, as you see, probably Lisa mentioned it earlier, what the Red QI essentially is incorporating quality improvement tools with the Red strategy that health workers and managers can use by the data they generate and the skills they need to foster local solutions. So quality improvement teams, which is as members from the community, the health workers, and other key members of the community form the quality improvement team who meet regularly to identify and analyze areas of need for improvement and seek solutions for local problems. And also we use extensively tools such as fishbone analysis to analyze problems and prioritize and understand their deep-seated causes. We also help to health workers to use the PDSA cycle to try change ideas and adapt that they find successful. Next slide, Samantha. Next slide, please.
So let me take over. Samantha, sorry, go back one more slide. I think Dr. Zeno is in Ethiopia and we're having a lot of connectivity issues. So what we wanted to really understand is, did the Red QI approach improve coverage and levels of protection? And really this question was being asked by the Ministry of Health, where we were seeing across the country, in particular in 2011, but ongoing, that there was high reported immunization coverage, but the country was still experiencing frequent measles outbreaks. And so at baseline, prior to implementation of the Red QI approach, we conducted combined immunization coverage and serology surveys with our partners, the Center for Vaccine Development in Baltimore, Maryland, and also with EPHI through within Addis. And also with various coverage survey teams. So conducted baseline surveys in 2013, then conducted and implemented the Red QI approach in 3 districts and 3 wardas, and then did end-line coverage and serology surveys in those 3 districts. And next slide. And so what we found was that the results from the serology really showed that more children were in fact protected against vaccine preventable disease from baseline to end line, so from 2013 to 2016. And we saw a statistically significant improvement in the percentage of children reached with routine immunization after Red QI. So next slide, please. So as Dr. Zeno talked about at the top of the presentation, we're really looking at this project in 3 phases because it was. So we started as the small learning grant in just 3 districts, using learning and evidence from implementation of the approach in those 3 districts. We were really asked by the Ministry of Health and the Bill and Melinda Gates Foundation to scale the approach. And so in 2014, we expanded implementation to over the next 5 years to an additional 100 districts across the country. And many of these districts are in what's called the developing regional states, where communities are dispersed pastoralists, but then we also spent quite a bit of time working in SNNPR and Tigray in rural remote communities, particularly in SNPR. So really had a broad range of contexts in which we were working in over this time period. Next slide, please. And so you saw this during this slide during the video, and I'm sorry, it was pretty quick. But through those years of working at scale, we were able to build the capacity of over 13,000 health staff, from district down to health facility, health post level, supported 2,700 health centers and health posts and 106 Warada health offices. And so really what we focused here on was really building capacity across the health system so that we're building the capacity of immunization managers in the approach, creating a supportive environment for local problem solving, and to really enable that community health worker linkage at the health post level, really engaging communities in the planning and designing of their own health services. So really linked at each level of the health system. Next slide, please. So this is a report out on some of our key successes. So we saw up to 93% of the primary healthcare units had functional microplans with maps of catchment areas and populations after implementation of Red QI. And, developing a bottom-up microplan was really the gateway activity. It was so critical in helping us really understand who are the children we are missing? Where are they? How do we reach them? How do we get resources to reach them? And really do this localized problem solving to do that. And that's where we had quality improvement teams at the district level. So with district administration to be able to look at problems from a managerial level, and then also at the health facility level, engaging communities in the quality improvement teams to really look at how do we increase service delivery and look at opportunities for behavior change through these communities and service delivery. We saw improved management by an average of 49% across key areas of immunization service delivery. So when looking at supportive supervision scores, those scores increased and improved over time. So in areas such as microplanning, vaccine management, community engagement, and also around data quality and use. We saw that health posts were able to execute planned immunizations sessions, and except for at 9% of fixed sessions and 17% of outreach sites. And then primary healthcare units improved in data quality and consistency across all reporting tools. So we had a lot of different work. So one of the main components of our work was to really focus on improving the quality of data at the point of generation. And this was focused through on-job training, supportive supervision, using quality improvement teams to do regular review of data and use data to improve the quality and consistency of data, really to encourage the use of data for programming at the health facility level to really build that accountability for data. And we saw huge improvements across the board at facilities, and probably because of this. Next slide, please. So the third phase of UI-FHS was really a transition to really focusing on institutionalizing the approach. And one way that we did this was to really focus our attention on building the capacity of health staff at the regional health bureau and zonal health department levels, and to really build their capacity through practical experience. So we continue to work in 11 WRDAs so that regional and zonal staff had an opportunity to support Red QI implementation at the district level, at the WRDA level. And so we worked in 5 regions, in 2 zones, and then 11 WRDAs for this third phase of the project, was about 3 years. Next slide. So integration of Red QI into regional programming. So our focus really here was on supporting the scaling of microplanning. And this, as we found through early implementation, microplanning really was almost non-existent when we started working at the WRDAs. And so really trying to institutionalize this process across the regions, not only in the direct WRDAs where we were supporting. And so we saw major scaling of microplanning with 75% of WRDAs now having a functional EPI microplan. And this was really a huge success, particularly in Afar and Somali regions where some of the WRDAs districts had never done a microplan before. And really when you're not planning for services, you're just rolling out static services. So this was a huge success and a lot of report back from everyone on how effective that approach had been. In addition, we really led the development of a customized and field tested RED guideline for implementation at the primary healthcare level. So we found that there really was a need to create RED guidelines specifically for implementation at the sub-district level in Ethiopia, and wrote guidance specifically for health center and health post staff to be able to operationalize the 5 components of RED and using quality improvement and as part of that. Next slide, please. So we, a critical part of our work was to really understand and help to develop and design a system where you could easily assess capacity within your team and track its improvement over time. And we thought this was particularly important at all levels of the health system, but where there was a lot of turnover within the regional health bureau. And it was important to understand on an annual basis where that individual team was regards to management capacity for the immunization program. And so we established a process to allow regional health bureau management to assess their staff capacity in 15 skills that are specifically important for routine immunization. And then data from these assessments drove programming and annual planning. In addition, respondents reported improvements in their ability to then support the zonal and district and health facility levels, and were really used these as opportunities to build their own capacity and to improve the way that they supported their teams down the line. Next slide, please. So based on our experience, we had a lot of opportunity over the past 10 years to really try to work to integrate our lessons learned and strengthen the immunization system within Ethiopia. And so opportunities to do that came through integration of the microplanning template as a national template, integration of the root cause analysis and fishbone tools into national guidelines. And so really using this as an opportunity to institutionalize the approach and improve the way that immunization programming is done in the country. Next slide, please. So as we started out as a learning grant, we really continued that throughout our 10 years. And we used our time really for continuous program learning, improvement, adaptation. So in the latter part over the past year or 2 years, we focused really on a couple of areas that stood out to us. One was integrated service delivery. So really looking at how does something so successful such as immunization microplan, how could it be adapted for use by other technical interventions? And so we did integrated microplanning with nutrition programming and rolled that out. And we have a great briefer on this that's available. In addition, we really found that there was a disconnect when we looked at trying to improve the use of data for programming, a disconnect between the use of supply chain data and immunization program data. And so really focused activities there to try to improve the way that that was done, both process and programming. And lastly, really driven by our desire to support Ethiopia reach their goals of really reaching every child. So looking, identifying and reaching zero dose and under-immunized communities, we really turned to look at urban immunization and designed a health facility assessment to really get better information about the urban health system IDs, what those health systems, what the health system is able to do, and their current ability to reach zero dose and under-immunized children living in slum areas. And we just, Tewodros just had a really excellent meeting with the Ministry of Health where we talked about these findings and recommendations being incorporated into programming moving forward. So again, briefs on all of these areas are available. Next slide. And that's it. And I'm so sorry that Dr. Zena wasn't able to walk us through this, but we want to thank you for allowing us to share some of our program highlights. So I'll just turn it back in case you two want to say anything.
I can only say thank you, Lisa, for completing this. Somehow I was let down by the internet. Thank you, and I'll continue if there is anything for clarification during the question and answer session. Thank you. Back to you.
Thank you, Lisa, for backing up, and thank you, Dr. Zena, as well. And sorry for the connectivity issue. So, as you saw from the presentation of Lisa, the project was implemented in 6 regions of Ethiopia. From the 6 regions, now 2 of the regions will share the contribution of UI-FHS project during its implementation in their respective regions. First, Awal Gudele from Afar Regional Health Bureau of Ethiopia will share the experience of the region with Red KY approach, followed by Tasfaye from SNPR region of Ethiopia. So, Awal.
We know the routine immunization program in Afar region, but the low coverage before Universal Immunization Family Health Service started, program was launched. The utilization and access problems where the coverages were low in our region, weak monitoring systems, no supportive supervisory checklist specific for API program, program-based specific checklist, regular supportive supervision and review meeting is not standardized in our region before Universal Immunization Family Health Service launched. As a regional and as a region, a lot of things improved, like our data. Then after, a lot of things improved, like as I mentioned. Standardized checklists developed and standardized microplan, red QI adapted in our region. Then after, a lot of things improved. UFIS organization supported a lot of activities like supportive supervision, capacity building, red microplanning, adaptation, a lot of things we have done by collaboration with UI-FHS. After UI-FHS project is starting, a lot of things improved. Continuous review meetings, like to review our progress in our region, is the Warada's progress, and by being in collaboration with the Universal Immunization and RHB, a standardized microplan is developed, and a lot of activities, a lot of things comes to standard. So supportive supervision is it comes to be a standard. We have discussed with our staffs and other advisories from the UI-FHS side. So most of the things are improved by being with Universal Immunization Family Health Service. So Regional Health Bureau, RHB, has been taken accountability and the commitment to sustain that the activities we have done with the UHFIS, sustaining the Red QI strategy, integrating with the partners, working on EPI through monitoring and follow-up for implementation of the Red QI strategies.
Good afternoon. My name is Tesfaye. I'm from SNNP Regional Health Bureau, and my responsibilities reproductive, maternal, child, adolescents, and youth health service director in SNNP Regional Health Bureau. Just to share you universal immunization through improving family health service organization support of our region, in short. So this organization worked for the last 2 years closely with our region, especially in strengthening routine immunization to reach un-immunized children, so that improves the utilization and service quality of routine immunization. They are supported, the support were in micro planning of EPI. So this organization took lead in EPI micro planning, to tell frankly. So we are benefited more in EPI micro planning to ease the facilitation of our SCAR resource by identifying hard to reach areas, so that we monitored the program in an easy way. So this was one support area of your organization. And the second one is capacity building in EPI, especially the program managers and health workers. Capacity building was your organization major support area. The third one is your supportive supervision and review meetings in monitoring, data tracking monthly, and feedback provision for health facilities, and also facilitating the supportive supervision and also review meetings, so that we can act on identified gaps. By doing so, overall EPI indicators performance were improved. When we see MCV2, measles second dose, which was a challenging area of EPI, from 48 to 75, which is great achievement. Fully immunized from 87 to 90. So our community benefited more from your organization, and I would like to thank this Universal Immunization through improving family health service project and organization as a whole staff. These are just to share your organization support for our regions.
Thank you, Awal and Tasfai, for sharing your experience related with UI-FHS project implementation in your respective regions. Now I give the forum back to Lisa. She will facilitate the next session. Lisa, to you. Thank you.
Hi, great, thank you. So we're now going to move into our panel discussion. And we are thrilled to be joined today by 3 distinguished panelists who will speak with us about practical strategies for identifying and reaching zero-dose and under-immunized children. So our 3 panelists are Dr. Carolina Danovaro, who is a medical epidemiologist with the Global Immunization Monitoring Team with the WHO. Dr. Ephrem Lemango, who is an associate director and chief of immunization programming with the health section with UNICEF, and Dr. Eric Sarriot, who's senior manager for country health systems in the health systems and immunization strengthening team with Gavi. So I welcome you all. Thank you so much for joining us. Excellent. And so, hello. Wonderful to have you all here with us today. So what we're going to do, I'll just run it through. We are going to ask each of our panelists 1 question, and then we'll hear a response from each of them. After a round of questions and responses, we'll open the panel up to questions from you all in the audience. And so that you'll have an opportunity to ask myself and our panelists questions. So as we're speaking, if you do have comments or questions for the panelists, please go ahead and write them in the chat box, and then we'll do our best to respond to as many questions as we can during the time that we have. Okay, great. So I'm going to start with Dr. Ephrem. My first question is for you. So in your former work, you served as the MNCH director in Ethiopia, and this was during the time when UI-FHS was scaling up. So we got an opportunity to work with you, which was wonderful. So in that role, what did you see as practical and feasible strategies to identify, target, and reach zero-dose children? And then now in your current role with UNICEF in a global position, what is your perspective on how best to formulate an effective and efficient partnership between, ministries of health and then supporting organizations to implement these strategies?
Thank you so much, Lisa. It's been a few years since my role in the Ministry of Health of Ethiopia, and I'm dipping in both hats now as UNICEF and at the same time as Ministry of Health. So I'll try to scratch as much as possible if I recall some of the details of this work while I was in Ethiopia. But I think much of the things have already been reflected by the colleagues who spoke about their work at the regional level and at the federal level as well. I think the time where the Red QI interventions were implemented in different districts through this series of stages, one of the things I recall is it's been part of an overarching commitment by the government by then to improving equity in general in the country. And that commitment of improving equity has been further translated into targeted health system strengthening interventions that were heavily focused on specific zones and districts in the country that had significantly lower performance in immunization and few other primary healthcare indicators. So I recall there was a plan called a routine immunization improvement plan, which was meant to guide the intervention of partners and the government to implement programs in selected districts that had a lower performance. And that specific plan was further supported by the government's commitment by then on the health sector transformation plan, which heavily focused on supporting regions to really work on improving equity to reach the unreached. And given that significant number of unimmunized children were in remote rural areas and pastoral communities, there has been a bold commitment that really helped the investment made. And I think, and the second and most important thing was this commitment led to a bit of improvement in investment, particularly in infrastructural investments such as cold chain capacity building. The government committed significant significant amount of investment to support regions through delivery of new cold chain equipments, solar-derived refrigerators in many health posts and health centers. And that was quite instrumental because you can have a wonderful RAID QI program implemented, but unless you don't have the right infrastructure, delivering the service will be difficult. So it has been augmented by such infrastructural support as well. And this led to, obviously, once this infrastructure was in place, the strengthening planning and micro planning was one of the critical impetus that was generated out of the RAID QI intervention by UI-FHS. One of the greatest limitations we had in every district was the planning was so general kind of planning where it does not necessarily emanate out of identifying where these children are. And it does not necessarily identify the key bottlenecks that are limiting immunization from reaching this specific population. So it was quite necessary for all of us to see not only reaching every district, but also reaching every child. And that required us to go below the district. Much of the guidance on reaching every district by UNICEF and WHO obviously focuses on how we can target programs at the district level. But it doesn't tell you, especially when it is in pastoral settings where people live quite spread across different places, and even in remote rural areas, reaching the district is not enough. So it really helped district health managers to plan in a much more detail with a proper understanding of which localities have how big of a population and how many children are vaccinated, under-vaccinated, and fully vaccinated. And they use that to guide their programming with a particular emphasis of conducting additional immunization sessions and also conducting supportive supervision. It turns out supportive supervision was quite predictive of improvement in program because it really encouraged people who are working on ground, and it also supported health workers who are the actual vaccinators to have the right set of understanding and the right set of support from the actual supervisors. And furthermore, in some places where reaching services were quite difficult, there was mobile teams that were deployed, which required additional resources as well, because in some places where reaching actually a specific number of children was difficult because you ask health workers to reach these unreached children, but they don't have additional resources, they don't have the vehicles to reach there, then it really requires to do things differently beyond the planning. So it is the amalgamation of what has happened at the national level and regional level and the support provided by this particular project really improved the planning at the district level and amalgamated with the support of by the government and many other partners really made sure improvements in these districts were achieved. And I think one important thing to note in here is the implementation of these specific activities was also further supported. I recall a meeting that usually gathered by the minister and the regional health bureaus that happens every 2 months, which presents a scorecard that shows green, yellow, and red of performance for every district to the regional health bureaus. And immunization was a #1 indicator. So when you present regional health bureau heads with a red scorecard that shows you are not performing well, it's really encouraged for many regional health bureau heads, which are the ministers in their regions, to actually perform well. So this continuous monitoring that was generated out of this work really helped to encourage commitment and allocation of additional resources at a regional level. What I have learned from my current role, I've just been in the post for the past 6 months, but during my duty missions also to different countries, and I was in DRC 2 weeks ago, where we were trying to evaluate the performance of the Mashako plan, which is basically a district-focused improvement plan. One of the things we have seen is these meticulous support and supportive supervisions and improving the number of vaccination sessions really play a key role in reaching many children that remain unreached. But one thing we have also seen is for partners like UNICEF, for partners like JSI and donors such as the Gates Foundation, it is really quite critical to start by understanding what the vision and ambition of the country or that particular area that we are supporting. And also based on this ambition is for the partner to be quite clear about what roles that they can play within that larger ecosystem. And that clarity really helps governments to know what exactly to expect from that specific partner. And one thing I have realized in my days in Ethiopia was the process of communicating results. Dr. Zenawi has been quite a strong advocate of that approach, and he used to always find a way of opportunities to come to me to show this is the result we are generating from district XYZ. And I think this gives us the impetus for us to expand. And that really encouraged us to see the importance of that specific intervention. So continuous monitoring and communicating results and further influencing a scale up. So I think on the third phase, I recall we had this significant appetite for us to go as quick and as wide as possible across the country. So I think this is what the lessons that can really be expanded to the other partners. It's understand what the government wants, be clear about what you can offer, and of course communicate results quite frequently so that you can influence further. Back to you, Lisa.
Absolutely. Thank you so much for those insights. And for going back, half a decade to think about that for us. Thank you so much. And, I think it really is so critical what you were saying, that point of really, communicating out data, really generating and building that culture of using quality data to then move forward to really putting data to programming. And that kind of brings me a little bit along the lines to the question we have for our next panelist. So Dr. Carolina, so my question to you is, there's been a recent focus on really identifying and then numerating zero-dose children. But I found in many ways, it feels as if we have a lot of data to target zero-dose children in missed communities. And perhaps the real challenge is resourcing and implementation. So from your experience, how can we better apply the evidence we have and move past assessments to actually implement solutions at scale?
Thank you, Lisa. I think you asked $1 million question. So let me backtrack a little bit. I think the immunization agenda mission and goal, it's incredible. It's not leaving anyone behind. It's to reach everybody, right? So the focus on zero dose, it's probably because those communities, those children are the ones that are the most vulnerable, the most left behind in a way. So yes, there's a lot of measurement, etc. But I think what the difference that the immunization agenda and this new focus, it's not only to count people, it's not only to know they are, but also who they are and why they are not being vaccinated. And it goes much beyond the counting and the administrative coverage, let's say, to really understanding at the local level. So that's why your project with the quality assurance, the quality part of reaching every district and reaching every community is so important, because it's empowering the communities to understand better where are the bottlenecks. It's a service provision, is it supply, but is it also the population that somehow there are barriers that are not being addressed in the regular way of doing things? So I think what is the difference is this idea of bringing the data to action, to the local level, and quicker, right? Because it doesn't make sense to wait until the end of the year to say, oops, we missed this many children or estimated many children in commune district X, but really we are missing these many children. Let's do something. Let's catch them up in the next microplan. Let's understand where their limitations are. And I think, as Ephrem said, really the commitment to act, I think it's what hopefully will make a difference. It's this commitment to equity. So what is the evidence? The evidence tells us that to reach everyone, you really have to understand what are the bottlenecks and what are the issues to plan accordingly. The evidence also tells us that one approach alone is not sufficient, that normally things have to be a multi-pronged to really address the different parts of the issue. So I think that's what we hope the immunization agenda and this focus, this renewed focus on the most vulnerable communities makes a difference. It's think maybe globally, big level, but act locally. It's really we haven't been able to make a difference in most countries in the last decade, right? Some countries that were not doing so great have improved, the rest have maintained or declined even. So what are we going to do different? It's to act quickly. These loops of assessment, action. There is a lot of talk about monitoring, evaluation, and learning. And I think in the past, we have done monitoring and evaluation, but the learning part, maybe not so much. And as Rebecca, who is in the call, Rebecca Fields once said, probably we should really be talking about MELA, monitoring, evaluation, learning, and action. Because if we learn, so what? We know a lot already, right? As you alluded to, we know that the RED and the REC approach are useful if implemented. Because in theory, they have all the elements, but about how each community, each country plans accordingly so that the local levels are able to do it, are able to implement supervision, are able to understand the data they are collecting, are able to act. And that is not a given. I mean, there are resource limitations. You may have I used to work in Latin America, where sometimes you had a wonderful plan, you did all the work, and then there was no transportation, no funding. The first funding to go was for operations, because it's easier. You have to buy vaccines, you have to buy supplies, but a supervision gets cut because there's no funding sometimes for that. So I think that bringing it all back together, this example of what you're presenting us, it's one way of really empowering and being systematic about implementing what the evidence tells us it can work, and doing it agile so that things can improve. Ephrem also alluded to this feedback and assessment. I used to work in the immunization program of the US 20 years ago. And at that time, there was the AFIC strategy, which was assess, feedback, and then really repeat, because nobody likes to see themselves as the ones that are doing poorly. We all want to do better for our communities. So it's empowering people. And that's what the evidence tells us. It's ensure that you understand the barriers, you understand what works well, and act and repeat. So I'll stop there, because I mean, what you're doing is incredible. And I really hope it can be adapted and adopted in many, many places.
Thank you so much, Carolina. And I couldn't agree more with you. And, I think one of the things we really are trying to push for is, just as you were saying, I think, thinking global, but really acting local, and really supporting really a culture of this localized problem solving, and really building those skills and a creative supportive environment for that to happen. That ACT part, as Rebecca Fields did say, so that, one of the key findings from our work has really been about stakeholder engagement, non-health stakeholder actors. So whether it be civil administrators or community members, getting them engaged so that there can be real dialogues about local resourcing. We have this problem, how do we solve it? And so I agree with you, absolutely. So thank you so much for your contributions. I think that there's no one maybe that's more at the top of mind as we think about maybe resourcing for immunization programs right now than Gavi. And so I'm happy to then ask our next presenter, Dr. Sarriot, I have a question for you, and I'm very curious to hear. So of course, as we were talking about earlier, it's hard not to think about the now, the urgency, but as we look to the now and then over the next several years of the next to IA 2030, what do you think is going to make the difference in reaching zero-dose children? And how do you envision Gavi's role in supporting innovations or programming such as this, or capacity building initiatives within the EPI?
Well, thanks for the difficult question. Well, I mean, I think, people that are, tuned in, to a very exciting presentation about your program, know about how Gavi is evolving, with Gavi 5.0, the focus on zero dose, the focus on having like logic models we call theory of change, and then all kind of things that come with it, like the focus on demand, community engagement, the CSO partners. I mean, obviously we're an alliance. So UNICEF, WHO, et cetera, we're an alliance, not just a donor agency, we're also an alliance. But even as an alliance, we've kind of committed to trying to engaging more partners to go there. And I think part of it is because of the need to go local that Dr. Carolina and yourself have emphasized. So in terms of what we do now, well, there's advocacy, to kind of say, hey, listen, the zero dose agenda, as you were saying before, the left behind, we want to build health system that reach the left behinds first. We don't want to be building a Rolls Royce for a category of people and then worry. We want to build systems that are equitable from the bottom up. With that, there's questions of, we're a financing organization. There's definitely questions about domestic resource mobilization and health financing country by country, right? The global communities and donors are not going to solve everything everywhere. We need to be strategic. And along with that strategy, another member of the alliance, the bank, is kind of one of the partners to look at health financing and resource mobilization. I used to be with an NGO, Save the Children, that had a big advocacy for domestic resource mobilization. So these things have to progress at the same time. And then, the civil society engagement. And honestly, we're trying to improve our health system strengthening approach. The health system strengthening team, nobody's, kind of found out how to, cook, make the cake of health system strengthening. We're trying to different thing. And I think we're trying to really build health system strengthening as a learning approach. So that goes at another level to the same kind of processes that previous, speakers have been emphasizing. So, I could go into the details about, what Gavi wants to do, and the mechanisms we have, the different funding mechanisms, but not just the funding mechanisms, but also the learning opportunities, the opportunities to bring stakeholders together, the MSDs, multi-stakeholder dialogues, the joint appraisals, the steps of reviews, the steps of planning. All these are opportunities to bring the stakeholder together, kind of at a national level. What you've been describing through RED, and RED QI happening at the local level. But then your question is a bit, tricky, because you say, well, what about, in 10 years? And in 10 years, we have, a transition framework, where, countries already in terms of procurement of vaccines, there's like a shift in who finances and procures the vaccines. And then the same thing happens in terms of transition programmatic. And so if you think about countries 10 years from now, all our countries, I would say, right now, lower middle income countries, there's a higher dependency on donor funds. But really, if you look at the next 10 years for all countries, including middle income countries, high income countries, and you look at immunization as a core benefit of primary health care, we know that zero dose is going to be a problem in a lot of places, right? We're seeing it with COVID. The first batches of COVID vaccine are being snatched very fast. And then the second batches, we're facing vaccine hesitancy, we're facing all kinds of factors. And that's not just lower middle income, that's high income, that's everywhere. And I think some of the ingredients that you've demonstrated through RED QI in terms of decentralization, of course, because the further away you are from the field, the more the picture is blurred and you need to be close to understand it, but also in terms of community engagement. We often think about demand generation. Of course, we need to have demand generation, but the whole logic of community engagement and engaging communities in quality, and whether it's framed like this or not, if you're engaging communities in quality improvement and thinking about quality, you're raising the health competency of the community, and you're raising some manner, even if it's not official, the social accountability of the providers. And if you think about these processes, they tend to be a little bit longer. You know, I mean, I like that you presented those 3 phases over a period of time. You know, my previous life, I was focused on sustainability. You don't build sustainability quickly. You build it with intention, proactivity, ongoing processes, focusing on the right outcomes, and being adaptive, and all these learning loops, which, you know, everybody has referred to, and which Red QI, you know, also embodies. So this is very important. And I think what we're trying to do now is work together with countries, with the Alliance, with all the partners to kind of build new habits for system. And I think you could almost summarize your presentations, you know, presentation of, our colleagues, you know, as building habits. I mean, global health is like any other field. We live with entropy. Systems don't, you know, sustainability is not about keeping things the way they are. If we keep things the way they are, they will degrade, they will erode, performance will go down, people get old, people get tired, people change. So the whole point of a health system that's a learning system is to keep this attention, so this monitoring, this learning. And then something that has worked yesterday is not going to work today, so we need to figure out why. So this attention, and that's the whole logic of QI, you know? So not just planning, it's planning with QI, attention to the details. And then there's many of us, we're all different, and that's true all the way down to the communities. And unless you have platforms where people can talk together, where people can learn together to understand problems, public health systems are not going to work. So I think that's what is part of the menu for the next 10 years for zero dose, is to really understand that the health system is certainly not just in the Ministry of Health structure. It's good to decentralize, but even at the decentralized level, that is not enough. We need to get to the local level, and not just go to the local level to tell people what to do, but to engage people. Because, I mean, we've known for decades what primary healthcare is and what it requires. And we need to bring the technicity, and I think that's your, you know, the red rec, you know, approach, you know, the technicity of micro-planning, bringing the professionals, and then the quality improvement, but the way you've been describing it, with engagement of communities. And, you know, recently we had at Gavi, we had a Gavi talk where one of your colleagues from JSI was among a panel of other potential, you know, partners, NGOs working in the field with efforts to reach communities with what we call fully inclusive approaches that built kind of a census of beneficiaries and then said, how do we act on that? How do we bring this information into the micro plans from the community level? So that's going to be, you know, an all of the above approach over the next 10 years to kind of get the big picture planning, the financing, but also continue bringing the habits to engage communities, and then get to a situation where zero dose or under-immunized communities become an exception. Then we have a health system that's able to respond to exceptions as opposed to dealing with 10, 20, 30% zero dose or under-immunized. So it's a big gamble, but what we're trying to do is build those habits, build this momentum now as an alliance. So I'll stop now and back over to you.
Thank you so much. No, I'm nodding my head along with everything that you're saying, and I absolutely agree with you. And I think we need to think about that big picture, but then also really think about what you were saying, and support and think about health systems from the top, but also really at that bottom level, at that community level, and have those community members also be those drivers for change, and let them really, from the bottom up, help us identify and tailor strategies so that we really engage them in the health system. And I really loved your point about, you know, I also think that sustainability is about adaptability and the ability of communities, countries, health systems to take an approach, but make it work for them. And I think that was one of the things that we were really excited about within Red QI, when we saw it taken to scale, it was adapted. It wasn't this perfect purified model, but it evolved to a place where it was helpful and useful to the people that were using it. And I think that's one of the big lessons that we learned from this project. So I want to thank you guys all so much. We have, I'm going to open it up. We have just about maybe 5 minutes for questions. And I've been told there is a question in the chat box. So from Enrique. So how do you see the health system strengthening capacity building component as a key component of Red QI on reaching zero dose children, specifically in fragile settings? So that's a great question. So I'll just say something, and then I'd love for any of our panelists to join in. You know, for us, our focus really from the onset of working in Ethiopia was to really build and design, integrate quality improvement methods and different approaches to strengthen the existing system, so that you're not creating a duplicative system, but that you're doing capacity building to help improve the current structure and system. And what we found particularly in fragile settings was we couldn't first start focusing specifically on quality improvement. We had to first focus on what were those essential building blocks to build the routine immunization system, and build that capacity first, and then integrate quality improvement. And so I really think that when we look at weak health system contexts or places where the health system is much more fragile, we really do need to look at, are those essential building blocks in place? If not, how do we build that capacity? And then how do we then move to really focus on quality improvement to get to those places within that health system? So I'll open it up if anyone has any other comments there. I don't know if anyone else.
I could just throw in something in addition to your point, Lisa, about the right blocks. So I'm not always a big fan of talking about building blocks, because we've done too much of that. But you're right. You need to have some essential, non-negotiable elements in place. But I think if you listen, if you listen to the stories that your project I've described, Dr. Ephrem's, Dr. Lemango, it's also not just having the right elements, but also making them work together. And there's a strong argument to be made that health system strengthening is not just building boxes of capacity, but making them work together. How does a district manager work with maybe some partners or NGOs or somebody that has a bigger reach into the local communities or local government? How do you get that to fit into the information system? How do you get that to get into actions? So all this is connecting work, and I think that's pretty much central to health system strengthening. Over.
Absolutely, I agree with you completely.
Would you like me to comment, Lisa?
Please go ahead, Ephrem.
Yeah, I think directed to the question, there is no any replacement for the health system strengthening work that is needed in countries. That is a very important imperative for immunization and other primary healthcare programs to succeed. Even though the investment is quite a long-term investment, it requires a huge amount of money from governments and also from partners, and it will need to be led deliberately by governments and communities. And that can only happen when there is a proper focus and investment in health system strengthening. I think the importance of health systems, we have also learned it from what we have seen in COVID-19. The pandemic has truly exposed the limitation of systems. Even the program like immunization, where we usually call it a resilient program, it's not necessarily, it has not necessarily proved that it is resilient in the eye of such a pandemic that really changed things. Not only the pandemic, but also at national and subnational levels, outbreaks tend to distract the way routine immunization is delivered. And any extra pressure on the health system, on primary healthcare settings, do distract how countries respond to specific problems they have. And routine immunization coverage tend to wind up and down. So what we have really seen is that investing in health systems, when we're saying health systems, sometimes it looks like it's a black box, but it's a very simple thing in a way that We have well-motivated staffs, particularly in the primary healthcare setting. And it's always difficult when it's fragile settings because the health workforce doesn't really stay there unless and otherwise uniquely motivated, supported. And it's to have the right set of supplies, particularly, for example, vaccination service to be provided. You need the vaccines, you need the cold chain equipments to really store that, and also to have the required operational financing that is necessary to keep the workforce in place, and also to make sure it supports supportive supervision, outreach work, and also increasing the number of sessions for immunization would be critical. And all this requires health system investment. I think on the wake of the pandemic, one of the things that we are witnessing and we're likely to see going forward would be, we are currently noticing there is significant backsliding on immunization coverage. We have 3.5 million more number of children who are 0 dose or who have not have any access to vaccine, particularly DTP1 globally. And some regions are significantly impacted when you compare it with the others. And these large countries, which are in the African continent, like Ethiopia, DRC, and Nigeria, do have the highest number of 0 dose children still, which would require strong systems to really reach these children. And due to COVID-19 vaccine, there seems to be significant awareness, or I would prefer to call it over-awareness about vaccines, where every little thing is scrutinized due to COVID-19 vaccine and the level of awareness created, which is likely to have a spillover effect also on routine immunization. That the things that parents used to accept as it is, now they are extremely aware that they would like to question in every detail of childhood immunization, which could have its own a bit hunking down of immunization coverage at some point in time. And finally is that countries these days do not necessarily have the resources necessary to cover costs of health services and availing the required investment for health system strengthening. Particularly, many countries have lost significant economic power at this very moment due to the economic crunch. And during the wake of the pandemic, there is a good likelihood there will be a decrease in health investment. So budgeting for health is likely to see a bit of dip down, which also translates to less budgeting for immunization and vaccines as well. So we will need to prepare as global partners, both these policy-making partners such as WHO, implementing partners such as UNICEF and Gavi, to really prepare ourselves that not many countries will transit to becoming self-reliant. And some of the countries that have already transitioned out are likely to come back to become much more dependent on support from Gavi. And we need to really keep an eye to avail our health system strengthening financial support through Gavi and also the other global platforms such as the Global Financing Facility and the Global Fund to really bring this together to support health systems in fragile settings as well. This is on top of the additional support that is already currently availed by Gavi as well for such conflict affected and fragile settings. In general, what really is going to drive the future is government ownership, country ownership, which spans not only at the administrative level at higher level, but also to the level of communities. And that is that one of the things that we have really noted how RED QI interventions implemented through your project really succeeded. It's because there has been strong community ownership and the lower level administrative bodies realized the importance, and that realization really helped to adopt and continuously refine the approach and ultimately succeed in the process. So I think that this is what we will need to witness. And as a final note, I hope project, I see that it's we're doing a closeout of UI-FHS obviously as a program, but I hope a closure for this one might be an opening for the next chapter. Thank you very much.
Thank you. Thank you so much. I want to extend a big thank you to all three of you for your comments. There is one last question in the chat box, but so I'll ask you, perhaps if you have thoughts, think about it. But Robert Steinglass wrote to each three of you, what changes might be needed by WHO, UNICEF, and Gavi to staff country efforts along the lines of RED QI? So if you can think about it, maybe right in the chat, we're going to go through just the last slides in the last 5 minutes. But if you have thoughts there, please do respond in the chat box. Thank you. So just in closing, what we really hope with Red QI is, really moving towards action, as Carolina had talked about during her session. And Red QI, we see it as an approach that can be used to drive behavior change at the management, service delivery, and at the community level. As we work to identify and reach zero dose in under-immunized children, there is a benefit to designing tailored strategies with those who can drive that change. And we really feel that national level policies certainly need to be in place. And we talked about this with Dr. Sarriot. But the localized strategies, those that are adaptive to the context and the needs of the communities, are going to be as equally important. And so nurturing the capacity and culture to develop local strategies, we think will be critical to reaching those zero dose children, as will the ability to mobilize local resourcing. So not just at the country level, certainly we've been talking about that. But what are those opportunities to really mobilize local resourcing as we can? And maybe it is financial, but maybe it's other means as well. Next slide, Samantha, please. And so what's next for Red QI? So we recently did a live course on Red QI through the Boost platform, but that course is still available for use by everyone and anyone, and it's on the Boost community platform. We also designed implementation guidelines specifically for immunization managers to be able to integrate the Red QI approach, or even components of Red QI, for example, the development of quality improvement teams, or the bottom-up microplanning approach into your immunization program. And that could be done at a national level, or if you wanted to pilot at a localized level, guidance for that. So after 10 years of implementation, we have a number of resources and tools that we think are going to be helpful for countries to take this approach on. Some of them are in Amharic and Somali language and focused on Ethiopia, but certainly others are in English and available. And we really do hope to be able to provide technical advice and support to other countries in their attempts to use Red QI to achieve goals really related to identifying and reaching all children in all communities. Next slide. So we have a number, sorry, I don't know, I'm not seeing the next slide, Samantha. There it is. Okay, great. So we have a number of briefs and publications. So again, if you wanted to know more, we have just published an article in Vaccine on the coverage and serology surveys. Those are the end-line baseline surveys on Red QI. We have equity briefers really focused on application of the approach to reach hardest to reach populations. As I talked about earlier, we have some really great briefs on data triangulation, integration of health services, capacity building at the regional health bureau level, and upper levels of management. How does that translate to service delivery improvement? So again, a bunch of briefs and publications. And then also, and perhaps more importantly, but we have a bunch of tools that are available. So job aids on planning for immunization services, bottom-up micro-planning. We have the created RED guidelines specifically for sub-district level, as we've been talking about. So those are available as well. Next slide, Samantha, and next slide. So in conclusion, we are so grateful and thankful for all of you for joining us today. I really want to celebrate and say thank you to all my colleagues. There were so many former colleagues and support team members that have really made this journey possible. And so I want to say a big thank you to everyone for your support along the past 10 years. And, we really want to hope that this approach will continue to be implemented, and it's through the institutionalized processes that we've had within the ministry, and that for this to continue in Ethiopia and to really see how we can scale and bring this approach to other countries, whether it be small scale or larger scale, but really thinking about how we do that with other ministries of health. And so again, please do reach out. This is my contact information. If anybody has questions, comments, would like further discussion, of course, the team is happy to do so. So thank you, everyone. We appreciate you joining us. And a big thank you to our panelists. Thank you so much. There's Twidros, okay. And I don't know if you wanted to say a big thank you to all of our colleagues and friends in Ethiopia who were able to join us as well. I know, and it's late for people, so we appreciate it. Thank you.
Yes, thank you for all of you, and we appreciate your time. Thank you. Have a nice day. Have a nice evening, wherever you are.
Thank you.
Thank you very much, Tedros.
እሺ አመሰግናለሁ። መልካም ምሽት።
መልካም ጊዜ።
Okay, thank you, Teddy.
Okay, Dr. Zena was online through the phone, so he followed us. Bye.
Okay, bye everyone. Thank you so much.
Thank you.